Switch gears to the area below the waist and talk about urologic issues. Our speaker is Dr. Michael Lazar, who is part of Northern California Medical Associates, heads up our urology division. And Mike has been a practicing urologist here in Santa Rosa for many years. He's living proof that other good things come from the state of Arkansas besides Mike Huckabee and Bill Clinton. Notice that was a fair and balanced
That was
comment.
fair and balanced, yes it was.
Mike did his medical school training all in Arkansas, and then residency in urology at Louisiana State, so he went a little bit south for that. So Mike's going to talk this morning about issues, urology issues in primary care, and we're grateful that he'll do this, and we look forward to hear what he has to say. Mike?
Well, good morning. I had the unenviable task of following Dr. Barry Mertz with that superstar presentation to then follow up with a more mundane, pedestrian set of topics. But I appreciate the opportunity to be here. It allows me to avoid doing the yard work that my wife is validating me to do in preparation for a shower that she's giving. So with that, we'll get going. My residency class had the unenviable distinction of being the first residency class to not be lifetime board certified. And so every 10 years, we have to go through the ordeal of passing the boards. And as I was doing it for the 4th time last year, there were topics that came up as I was sitting through interminable review courses that showed me that I really didn't know everything I thought I knew about some of the mundane, pedestrian aspects of urology. And so as I was trying to pick topics for this talk aimed primarily at primary care offices, I thought this would be a good opportunity to share some of the newer information that we otherwise may not be hearing. So these are the topics that we'll cover today, and some of it is very routine, and others are more exciting and new. And we'll start with the urinary tract infections. This is pretty common, uncomplicated cystitis. We like to treat it for 3 to 5 days, although 80% of them will get better with 1 dose of antibiotics. The problem is that their symptoms continue for 2 to 3 days while the bladder heals from the inflammation, and so you get a lot of phone calls. So most of us will treat them for 3 days, and if it's been there for a long time, maybe 5 to 7 days. Current recommendations for first-line therapy are for nitrofurantoin or trimethoprim sulfamethoxazole. Amoxicillin or ampicillin is good for gram-positive organisms, but the great majority of gram-negative organisms are resistant to it now. And they're really asking us to reserve quinolones for resistant germs. For non-sepsis pyelonephritis, you can treat them for 7 to 10 days. Don't use nitrofurantoin because while it gets good urinary levels, it does not get tissue levels. And you have to have tissue levels to treat pyelo. If a patient is septic, then you treat them with IV antibiotics for 2 to 4 weeks, and if they were in septic shock, they need to be treated for 4 weeks. In men, we usually don't think in terms of treating bladder infections because they almost always will include the prostate. And the prostate is a difficult organ to achieve antibiotic levels in. The 3 areas in the body which are difficult are the brain, the prostate, and the testis. And it's because the vessels have a lipid layer around it that make it difficult for the antibiotics to perfuse. And so you have to treat longer. So with prostatitis, you want to treat at least 10 days. A recent study showed no advantage after 10 days, but clinical experience and numerous other studies over the years showed that it may take 4 to 12 weeks, and at 12 weeks they still have a 10% relapse rate. So I tell the men to treat until they're feeling normal for 7 to 10 days. And if they're septic, you treat them the same way we do with the women up there. Now I put that slide in to introduce this one. And this is a big topic in hospitals and Of course, in our offices where we have an increasingly elderly population, a lot of them are running around with Foley catheters, and so the issue of infections is a big one. The first thing to know is that you cannot prevent infections with Foley catheters. Approximately 10% of patients per day will become colonized, and within 2 weeks, about 95% of them have positive urine cultures. It's interesting to me that whenever a patient who has a Foley catheter gets ill, everyone assumes that, oh, well, there's an infection in the urine, it must be that, when in fact it may very well not be the urine that's causing the problem, because the colonized urine with a catheter usually does not cause any health issues. The newer concepts are that we should avoid using antibiotics to prevent emergence of resistant organisms. Now, this process begins to happen after about 48 hours of antibiotic exposure. You cannot sterilize a foreign body in the urinary tract. So if a patient has a catheter or a ureteral stent, they should be changed if you intend to make their system sterile. But again, in most patients, a colonized foreign body does not cause any health problems. If you have a patient with a catheter and they're having persistent bladder spasms or persistent episodes of hematuria, and they're really pushing you to treat them for only 48 hours, again, to help prevent the emergence of resistant organisms. And the best practice is to change the Foley catheter as you're treating it, because then you have some chance of getting some sterility. Although, as I said, it won't be for long because they're going to colonize again. For recurring sepsis in men, you should consider putting a suprapubic catheter in. The prostate, again, is the problem in men with catheters, because as the bacteria propagate along the catheter, not inside the catheter, but along the catheter up the urethra, they get into the prostate, and when the catheter is sitting on the prostate, these men develop acute prostatitis, and that's a severe infection. And so in them, if it's happening recurrently, you can put in a suprapubic catheter. The interventional radiologists do it. They just poke it right in through the skin and the lower belly into the bladder, and it's no longer on the prostate and much less likely to cause sepsis. Never test urine from a bag unless it's a brand new bag you just put on, because bags are always contaminated. You want to clamp catheters, let the urine accumulate in the bladder, empty it out into the specimen cup, or if they have a bed bag, they frequently will have portals where you can aspirate urine from the tube, but again, it should never come from the bag. The biggest thing they were hammering on us to change our behaviors on when I last took the boards was the usage of estrogen creams in postmenopausal women. The initial push was because they had studies that showed that women who were having an average of 8 infections per year, bladder infections, were told to apply a smear of estrogen cream on the urinary meatus. Now, not applicator quantities. We're talking about just a tiny little dot, pea-sized, and that's PEA. I am a urologist after all. Pea-sized amount of the cream, and just smear it on the urinary meatus. And it works very nicely. The women with an average of 8 infections per year started having an average of 0.5 infections per year. And that's the same as it is for premenopausal women in terms of normal. The issue is that they must hit the opening. And so, as it says at the bottom, it may be helpful to have the ladies sit on the toilet with a pocket mirror, see where the urine comes out. It's astounding to me how many older women don't have any idea where the urine comes out or what their anatomy is. Their parents taught them, don't focus down there, don't touch down there, don't do anything, it's nasty. And they have no idea. So when we show them the pictures or get a mirror around, show them, they say, oh, well, under vision with the mirror, they can apply it a few times, and then after 2 or 3 applications, they'll know by feel where it is. The problem we sometimes get into is that they get it on the clitoris, and if you put the estrogen cream on the clitoris repeatedly, they'll complain of issues of burning or itching or sensation down there. And some ladies tell me they start having dreams they hadn't had for 30 years. So it's important to make sure that it's targeted correctly. Now, an important issue here is this note. Now, when you're using applicators, quantities of estrogens for menopausal symptoms, it's true you can have the ladies do it 2 or 3 times a week, and it's enough to keep the symptoms at bay. But if you're only applying a small smear onto the urinary meatus, it has to be done every night. And so please, if you see patients coming out of my office or any other urologist's office and we're told to put the estrogen cream on their urinary opening every night, please do not tell them, oh, you only have to do it 2 times a week. That is not the case. One of my pet peeves. When you begin to use the estrogen cream, the changes that are beneficial begin to occur at about 6 weeks. In the case of infections, what happens is that the acid levels in the vaginal secretions in premenopausal women are higher, and it makes it a more difficult place for bacteria to grow. But in postmenopausal women, the acid levels fall, the pH rises, and bacterial growth is quite a bit more abundant, and that allows them to colonize their bladders more easily. And this reverses just by putting the smear on the urinary opening. Now, what they also found was that, gee, the overactive bladder that we're always hearing the ladies complain about also seems to respond to this treatment, again, in 4 to 6 weeks. And there are a whole lot of ladies who come in and we put them on this and they no longer need bladder pills. Sorry, Stellis, I apologize for that. And they don't get the side effects of the constipation, the blurred vision, CNS problems, etc., and dry mouth. So please think in terms of the estrogen application. In addition, women who've had breast cancer, where we usually try to avoid estrogens at all costs, because applicator quantities do raise your serum estrogen levels, smearing a little bit on the urinary meatus does not raise the serum estrogen levels, and so doesn't have the same risk. Next subject, imaging for hematuria and suspected stones, and this is again one of the things that I see quite a bit, and it's a little bit irritating. Ultrasounds are really good for things they are really good for, but what they're not good for is hematuria or suspected kidney stones. The ultrasound is very good at looking at the parenchyma of the kidney, and it's good for determining whether something is cystic or solid. It is good for seeing hydronephrosis, which is a blockage and a swelling of the plumbing inside the kidney. And it's good, it's the proper study for someone who's had recurring urinary infections. But if you're looking at hematuria, which could be cancers of the kidney, the collecting system of the kidney, the ureter, or the bladder, it's not a good study at all. It misses a lot of things. And in stones, it not only misses stones frequently, but the size of the stone is important in terms of treatment planning, and the ultrasound is notoriously inaccurate in measuring the stones. So if you do have someone that you suspect has stones, get a non-contrast CT scan at Redwood Radiology, or St. Joe's they call it now. It's called a stone study, and it's right there. It's abdominal. It's under the abdominal and pelvic CT scan, and it's called a stone study. There's no contrast. Now, if you have hematuria, you want to get a CT IVP, which is a CT scan with and without contrast. The reason why the without contrast is important is because stones are exquisitely imaged with CT scanning without contrast, but a small stone will have, with contrast, will be completely invisible because of the presence of the contrast. So if you have hematuria, get the imaging study, and if you like, you can get a urine cytology, which is helpful, and then send them over to us for cystoscopy, and that would complete their workup. Now, we should work up both microscopic and gross hematuria, and that's something that's changed over the years. When I was a resident, there was a study that followed 4,000 women with microscopic hematuria, and what they found is that if a woman not men, but women, if they were non-smokers, had no symptoms, and had not been employed in a occupation where they were exposed to toxins or radiation, then the incidence of positive findings with a workup was so small that they didn't recommend working those women up unless they developed symptoms or gross hematuria. But now the American Urology Association has changed that recommendation. They say just work up all microscopic and gross hematuria, men and women. Pelvic organ prolapse. I don't know if any of you have time during the day to watch the talk shows or the View or any of the news programs, but when the commercials come on, it is striking how many attorney groups are advertising for mesh patients that they are taking physicians to court. These mesh operations for prolapse organs and bladder dropping, so forth, are good operations. I like them a lot, but the medical legal risk is just so high that we've given them up altogether. None of the urologists in Santa Rosa will do them. And Dr. Bob James, who most of you know, was actually an instructor for one of the mesh companies. And he won't touch them either, for the most part. And we send them down to UCSF or Stanford and let them do it, because even if you fully consent them, they're going to come after you. And even if you can be exonerated of any blame, it's still a hassle and it's expensive. Now, I'm not sure whether the GYN docs in town are still willing to do them, and you can certainly talk to them about it, and they should be here. PSA. This is a subject near and dear to my heart, and I think it's important that we look through this. The U.S. Preventative Services Task Force is a group of family physicians. There are no urologists, no oncologists, no one who is a specialty in the group. And in 2012, they evaluated PSA screening and prostate-specific antigen. For those of you not familiar with it, it's a screening test for prostate cancer. And what they determined was that it does more harm than good, and so they gave it a D rating. Now, this group refused to consider that the European Urology Association found that there was a 26% drop in prostate cancer mortality. And in the United States, after this recommendation came out, there was a meta-analysis that found a 40% drop in prostate cancer mortality since the PSA era began. So if we stop doing PSAs, we go back to what we were doing 25 years ago, only it's worse, because now a lot of docs don't do rectal exams, and so we don't find them at all. Back in the days, before PSA, when a patient had a lump on his prostate and they were referred, most of them were already metastatic. Now, less than 5% of them are. And so PSA is still a good test to do at this point. The real problem with PSA is that it's not specific enough. It finds not only the dangerous prostate cancers, but it also finds the many, many prostate cancers that are low-grade, slow-growing, and never intended to be clinically significant. And the issue that the task force raised was that in patients who were diagnosed with these low-grade prostate cancers that were never going to be a health issue, they now have a diagnosis of cancer, and they then get more close follow-up, and with the active surveillance protocol, they have PSA and digital rectal exams every 6 months, repeat their biopsies in a year, and if everything remains stable, repeat the biopsies every 2 to 3 years, knowing that 40% of those cancers are going to advance and require treatment, 60% will not. The other issue, and this is a blot on my specialty, is that there are a lot of physicians who will treat patients unnecessarily for a profit motive. And the geography of this trend is striking. The active surveillance protocol, where we watch rather than treat, was developed and championed by Lori Klotz at the University of Toronto and Peter Carroll at UCSF. If you live in the northern United States or the western United States, over half of the patients that we have with prostate cancer are followed with active surveillance. If you live in the eastern United States or the southern United States, about 5% are followed with active surveillance, and all the rest of them are treated. And it's a striking trend. The other issue is that the American Urology Association published statistics showing that in communities where the urologists buy into Da Vinci robots, which is the most common operation on which is radical prostatectomy, they found that the incidence of radical prostatectomies per 1,000 population tripled, and over and above what it was before. And so the treatment for, well, go back here. Treatment for unnecessary for profit is a real issue. Now, fortunately, there are genetic tests being developed, initially on prostate biopsy tissue, but now blood testing, where they're finding the ability to determine who has a high risk of developing a high risk, dangerous prostate cancer. And the genetic testing is not identifying patients with the low risk innocent cancers. And so that is likely to replace PSA in the next 3 to 4 years or so. But until then, we need PSA. Please keep doing them. Now, screening, let's talk about that for a moment. Screening is misunderstood by definition by a lot of people. Screening means you set up a booth at the fair, and every guy that walks by, you do a PSA and or a rectal exam. Screening, yeah, screening is not screening if a patient has any urinary symptoms at all. It is not screening if a patient has a positive family history of prostate cancer. And so the screening definition is misunderstood by a lot of people. So again, if men have symptoms at all of urinary prostate symptoms, or if they have positive family history, insurance will pay for the test, whereas they sometimes balk if you just put the screening code on there, but you can still get it done. Now, prostate cancer therapies are really four for localized prostate cancer. You can do surgery, which is open or robotic radical prostatectomy. You can do some form of radiation therapy, and for many years, that's all we had, and we would counsel the patients on the equivalent effectiveness of radiation and surgery, and based upon their fears and preconceived notions and understanding of the morbidities with each one, they would pick one of the treatments. More recently, though, it's been shown that prostate cancers will respond to temperature extremes. So the first treatment that came out was cryotherapy, and cryotherapy is performed where under anesthesia, needles are placed through the perineum into the prostate, and liquid argon or liquid nitrogen is used to freeze the gland. And on the screen, you literally see an ice ball develop that encompasses the whole prostate, and then you thaw it out and let it shrinks down, and then you do it again. And there's 2 cycles of it. And it's pretty effective, just about as effective as radiation and surgery. The problem is that the nerves that tell the penis to get erect live right outside the prostate capsule, and the ice ball is not that well controlled. So it almost always hits the nerves, and the erectile dysfunction rate is above 90%. More recently, there's been developed heating of the prostate tissue. High-intensity focused ultrasound, or HIFU, is a near and dear subject for me. I started doing them back in 2007 and have continued doing it and have been part of the development of the technology. The high-intensity focused ultrasound, it very precisely places heat. It's literally a probe in the rectum, like when we do imaging and biopsies, only we can also send treatment ultrasound across the rectal wall unfocused, and the temperatures stay low. And then where the energy focuses in the prostate, it creates a 3 millimeter by 3 millimeter by 12 millimeter cylindrical shaped area of heat that's 200 degrees. immediately surrounding that heat is normal temperature. It's very precise. We can treat part or all of the prostate, and we can map the neurovascular bundles outside the prostate where the erectile nerves are and avoid them much more assuredly than we can with radiation or surgery. The recent, the ongoing, new subject of hot debate in urology is whether the prostate cancer can be treated in just the cancerous portion of the gland. Historically, surgery and radiation treated the whole prostate, and so did these other two modalities. But the cryotherapy and HIFU allow you to treat very portions of the gland where the cancer is. And there are studies out of London that showed that when you treat just the cancerous portion of the gland, the cancer control is actually very good. And because you're staying away from the urethra and the erectile nerves, the side effect profile was the same as the sham operation that they performed. And so it's likely to be the way many prostate cancers are managed if they are appropriate. Now, to be appropriate, you have to have a new type of MRI which has been developed over the last few years called a multiparametric MRI. And this MRI basically looks at the ability of water to diffuse between the cells in the prostate, and knowing that cancer cells are more tightly packed, so water doesn't diffuse through as easily. And also, gadolinium is administered as a tracer, and it makes the tumor vessels blush, and so it aids in diagnosing these cancers. Now, this MRI is good at seeing high-grade cancers, not so good at seeing low-grade cancers, but that may not be a bad thing because, again, many low-grade cancers shouldn't be discovered. But it is a useful tool in men who have rising PSAs. We do biopsies, the biopsies are negative, and yet the PSA is rising, and so it gives us something else we can do to look for targeted areas. And by the same token, in treatment, we can do the same thing. The high-intensity focused ultrasound, again, is something that I've been involved with. I was one of 3 FDA proctors for the study around the country, and one of 5 instructors for the procedure in the nation leading up to its release, we hope, later on this year. On October 1st, the FDA had the advisory panel, which an advisory panel is university professors that they invite to come, and there were urologists, oncologists, nursing, engineering people around the table with 3 FDA people, and I testified with it and was impressed at what I saw. The chairman at Johns Hopkins, Pat Walsh, who is Mr. Radical Prostatectomy, successfully lobbied the other professors to ask for longer follow-up. There are interests that really want to see this technology delayed in its approval, and we can go over that some other time if you like. But nonetheless, he got the panel to say, yeah, 5-year follow-up wouldn't be a bad idea, when the FDA had set the program up for 1-year follow-up with repeated biopsies. And it's because they do the repeated biopsies that you know the patient is cured if their PSA is down. And so the FDA, when you're at an FDA trial, it's like being in Supreme Court. You expect a certain decorum. Well, I was astonished. The professor said, and Dr. Walsh especially at Johns Hopkins said, we want 5-year follow-up or longer. And the FDA chair stood up and yelled at the panel. He says, you cannot change the parameters of this study at this table. Well, the CEO of the company was sitting next to me. He says, that's because we've already spent $20 million on the study, and if they change the rules right now, he knows we can sue them. So there was this contentious fight, and the professors literally leaned back and did this. And so they said, well, we won't vote for immediate approval. Well, within a week, the FDA chair was at the company and said, we think we can, they don't like to approve something without advisory panel support, because if there are complications afterwards, it makes the FDA look bad, and they've been criticized a lot lately. So the FDA chair came in and said, you know, we can consider this for approval for just tissue ablation and not specifically a cancer application, because around the world, there's some people who use it for BPH. It's slow, it's tedious, it's like watching paint dry to do one of these procedures. And there's much better treatments, from my point of view, currently available for BPH. But for prostate cancer and tissue ablation, it's good. And plus the FDA is under a lot of pressure because around the world there's HIFU for breast cancer, HIFU for kidney cancer, liver cancer, brain, and they're under a lot of pressure to get this technology approved, and they're just trying to find some way to do it. But the hope is that the final set of cases were submitted to the FDA for this de novo classification in March, and they have 180 days to consider it. And so we hope that it'll be approved by 2015, or October 2015. Until then, I travel to Puerto Vallarta and Toronto to treat these patients, and we'll be going next week while my wife is hosting the shower and she is distressed. All right, do we have a moment, can we fire up that little video just to show what it is? It's on the jump drive. This is like a 2-minute video, and then we'll have questions. Or we can have questions now while he's doing that. Yes?
Could you comment on interstitial cystitis and whether or not the topical estrogen and
I'm sorry, whether or not topical what?
the estrogen treatment and helps override the bladder is helping for that, or anything?
My feeling is that with the understanding of the interstitial cystitis, which is an inflammation inside the wall of the bladder, is caused by a permeability problem in the bladder. That is, the glycosaminoglycans or GAG layer of mucousy lining is lost in those ladies and men, the few that have it. Chemical irritants more readily diffuse across the wall and cause an actual inflammation in the wall. My instincts tell me that just smearing a little estrogen on the meatus won't help that at all. But a lot of these women have both, and so it'll help that component. For interstitial cystitis, same thing. I don't think it changes the GAG layer. It doesn't repair the GAG layer. Interestingly, the GAG layer is almost identical to heparin, and so one of the most effective treatments is to have the ladies come in several times a week and put heparin in their bladder. It makes a huge difference. So when they're having an attack, this will calm them down. Yes?
How do you repeat the CT scan to use that normal scan and they continue that maturity? There are lots of patients who say, oh, I had it forever.
Well, there's such a thing as benign familial microscopic hematuria. And again, if you know that's what you have, it depends on how comfortable you are. I've heard some sources recommend a workup every 2 or 3 years. Others say, nah, if it's not there, it's not there, and wait for the gross hematuria.
Hi.
Yes.
I'm a family physician, so screening is what I do, and you capture part of the screening, verifying what I do, grab guys from the screen, and you do things with that. So that's part of the screening. The other part of the screening, you need to have an intervention that alters the natural cause of the disease. And I think that's one of the issues with the PSA, and that's one of the issues with sort of saying, you know, after the PSA screening was introduced, we kind of brought up mortality and saying this is different PSAs. It seems a lot of the mortality benefit is due to treatment, so studies that look, you know, that's early detection of prostate cancer leads to better outcomes. I think it's very questionable whether it gives better outcomes. It seems to be really the treatment that advances and allows for improved outcomes.
No, I would differ with that. The improvement in mortality is in the earlier diagnosis of the cancer. The surgery hasn't changed in terms of how you remove a prostate in all these years. Yes, we protect the nerves, but the cancer control aspect of it hasn't changed at all, and yet there is that improvement.
The other part of the sort of screening and, you know, does early detection or treatment improve mortality? You know, when you look at the studies that sort of show improvement in mortality, the other really important question is what's the number of needed to treat to save one life? And it's not one, you know, it's not two, it seems to be in the 40s, right? So for one patient to benefit, you need to put, you know, 40 men for fairly, you know, significant treatment.
No, let me explain that away for you. If you are in the eastern or the southern part of the United States where all prostate cancer is treated, you're correct. You have to treat a lot of patients who have not dangerous prostate cancer in order to save the life of the one who has the aggressive prostate cancer. But if you use active surveillance and you don't treat, men with Gleason 3+3, the low-grade prostate cancers and stable PSAs don't need to be treated. They should be watched. And if you then cull all those people out, then the prostate cancers that are higher grade have a much better yield for preventing prostate cancer mortality. The intellectually lazy, that's probably too strong, but it's the aspect that a lot of non-urologists have done. It's always easy to hang your hat on a headline instead of reading the actual article and saying that, oh, prostate cancer doesn't need to be treated because it doesn't really save lives. That's true if you're treating cancers that don't really need to be treated. In the FDA study that we're working on, the FDA is about to decide that Gleason 3+3 cancer isn't cancer. But the pathology groups raised hell and said, no, it is cancer, you cannot take that distinction away. Well, the higher grade cancers, grade 4, grade 5 cells, no one argues that those are more aggressive and that they will kill a patient. So if you're primarily treating those patients, your yield of saving lives is much better than if you're just treating everybody that gets diagnosed.
Comment and a question on men who've had radiation therapy for prostate cancer. Some small percentage, maybe up to 5%, will develop radiation cystitis 5, 10, 15 years down the line.
Actually, it's the latest study was at 22%.
Oh my, well, the treatment that is largely not known by family practitioners, counting myself in my earlier days, was hyperbaric oxygen therapy, and it's highly effective. If men are referred within the first 6 months of hematuria, study by Chong shows up to a 95, 96% resolution or improvement in the bleeding, which can rarely be fatal. Now my question is, with regard to your comment on mesh, does that include the sling as well as mesh for pelvic prolapse?
Wait, say that the last part again?
Does your comment about the risks of mesh for pelvic organ prolapse,
yes,
does that include the sling procedure?
Yes, it does.
So both combined. Thank you.
Yes?
Yeah, regarding the multiparametric MRI.
Uh-huh.
The multiparametric MRI, is that a different magnet or is that a protocol that can be applied
It's the same magnet. The local radiologists are starting to do it. The technique was developed and I think still done best in the country at UCLA. Robert Margolis down there developed a system where they rate the suspicious areas on a scale of 1 to 5, with 4 and 5 being the really dangerous ones and the ones that are less rated being less so. So if we can get our radiologists to adopt that scale, it's a really helpful tool. I've sent a few people to UCLA. Stanford does a good one. The local guys are getting better. The main thing is that we need for them to very specifically describe the location of any suspicious area so that we can do targeted biopsies of that area.
I just have a quick question on going back to the cystitis issue back here in the front. And just regarding the empiric treatment, you mentioned macrobid and Bactrim primarily, and I've been finding on the vast majority of urine cultures that the Cipro class seems to not only be more sensitive, but often I'm finding that the TMP SMX is resistant or just less sensitive.
No doubt about it. But the quinolones are becoming more resistant, the germs are becoming more resistant to the quinolones because of overutilization.
Okay. So recommendations still favoring towards macrobid or Bactrim over the Cipro unless they're complicated?
Initially, if it's an uncomplicated cystitis. And I think it's very important to get cultures. You know, in the old days, you'd get a culture, and if it was positive, they didn't do sensitivities unless you requested sensitivities. But you need culture and sensitivity to really know what you're doing with infections now. And sure, over the weekend, people call in, and you call in whatever you're going to use. But the optimal treatment really is to get a urine sample so that you can know. Yes?
Hi. Yes, as far as the prostate cancer, my uncle, when he was 80, was diagnosed with prostate cancer, and because his life expectancy is, they did the watch and wait, because they expected him to not live longer than 10 years, which was the criteria. So at age 88, he had metastasis to his lung and ended up with a lobectomy, and he deteriorated from the lung cancer. He's 91 now. So my question is with people living longer now, or men living longer today, is it appropriate at age 80 to say, okay, you're not going to live more than 10 years, we shouldn't treat this?
Well, it really depends upon their physiologic age rather than their numerical age. I asked Peter Carroll at a lunch 3 or 4 years ago, the chairman at UCSF and one of the prostate cancer experts in the country, what he's doing for men who are over 80 with mildly elevated PSAs. He says, interesting you should ask. He said, because until just recently, I would tell them, don't worry about it. If you get prostate cancer, we can usually control it with hormone therapy, et cetera. But he says now he's in charge of the CAPTURE group. It's Carcinoma of the Prostate Strategic Urologic Research Endeavor. It took me 2 years to remember that. But it's the nation's largest computer population of prostate cancer. And what he found is that in the old days, since the Frank study in 1954, we knew that men who were older that got prostate cancer had prostate cancer that was less aggressive. And so what all of us learned in med school was prostate cancer in an older man is something you die with and not of. But more recently, what Peter's finding is that the group with the fastest rising rate of aggressive prostate cancers is the guys over 80. And going back to the physiologic age, you think about it, when I was a kid, an 80-year-old man was late for the grave or already dead. Now we've got 80-year-old men skydiving due to better lifestyle and health and so forth. And I think that if they're more, and since they are more vigorous, I think their cancers are more aggressive, more like younger men's cancers. And so I don't hold to that age as firmly as we used to in the old days.
We're bumping up against the break now, so why don't we go ahead and
all right, let's do that little.
Please do that. Let's see
a couple minutes in
your video, and then we'll wrap this session up.
So this is a probe in the rectum, and that's the prostate. Is there sound? Do you have sound? I mean, I can tell you what it's doing. So guy's under anesthesia, he's in stirrups, and this is in the rectum. And so we treat usually in 3 zones in a small prostate, maybe 2 zones, anterior, middle, and posterior. And that's showing the outlining of the treatment regions. I can hear a little sound. All right, so when this fires, it fires for 3 seconds. And when it does, it creates that 3 millimeter by 3 millimeter by 12 millimeter area that is 200 degrees. And 200 degrees kills both benign and cancerous tissue. There's one of the lesions. And we literally go from bottom of the prostate to top of the prostate in a straight line. And then we go to another region and go in a straight line. And we can very precisely determine which part or all of the prostate that is treated. And in a total gland treatment, you just fill the prostate up with these little cylindrically shaped heated elements, and that kills the tissue. This procedure is painless, almost completely bloodless, and the side effect profile is much better than surgery and radiation in terms of incontinence, erectile dysfunction, etc. Now, because you're destroying the tissue, it does heal with a higher incidence of scar tissue. When you're doing radiation treatments, maybe 5% or so will get a dense scar in the prostatic urethra. In surgery, up to 10%. This is 15 to 20%, and we have to manage that. But usually you can just dilate those in the office, or under brief anesthesia, put some little cuts into the scar, and it keeps it open. All right, thank you very much.
Thank you very much, Dr. Lazar.